Hi, we are excited to welcome you to Parks Associates' 8th Annual Connected Health Summit. Typically, we host the Connected Health Summit at the end of August in sunny San Diego. The event takes place across 3 days, including a night out at the ballpark. But this year, like last year, everything is different. Instead of hosting across 3 days, we will bring Connected Health Summit to you across the year, featuring virtual sessions focused on the impact of COVID-19 on the connected health market and current consumer attitudes towards virtual care and remote monitoring solutions. 2020 was an unprecedented year in healthcare worldwide. The COVID-19 outbreak and resulting public safety measures led to sharp decreases in in-person visits, the delay of many elective care procedures, and dramatic changes in how healthcare is accessed by patients and delivered by providers. This year's event, Connected Health Summit, Consumer Engagement and Innovation, addresses opportunities for new solutions, including smart home platforms, telehealth services, voice assistants, and wearables to empower consumers, caregivers, and providers with new insight into patient health. Providers must rise to meet the growing demand for services in independent living, chronic care management, remote access to care, and wellness and fitness. New business models, technologies, and solutions are providing a more consumer-centric experience. Telehealth and independent living solutions are extending healthcare and enabling care delivery to a larger market, with specific impact on elderly, patients with chronic conditions, rural households, and caretakers. We look forward to sharing more of our research across the year and bringing you the industry leaders in the connected health industries. We look forward to seeing you in these coming events.
Good afternoon and welcome to our first Connected Health Summit virtual session of the year. I'm Jennifer Kent, Vice President of Research at Parks Associates, and so pleased to be moderating this session today, where we are focusing on connected health use cases, particularly new use cases given the impact of COVID-19, and in particular the role of devices and sensors in the larger connected health ecosystem. So today's session, as you heard Elizabeth just mention, is one in a series of sessions we'll be hosting all year, with some particular session deep dives happening in that late August, early September timeframe, when we typically have our in-person event. We hope to get back to San Diego next year, but we're excited to have this opportunity to have these conversations more frequently throughout the year due to the virtual format. If you're new to Parks Associates Connected Health Summit, our event does cover the connected health markets on several fronts, but particularly in those ways where connected health bridges the gap from facility to the home, with a particular focus on telehealth solutions, the independent living market, and connected wellness and fitness. Today, we've got 2 hours together, so I'm going to kick off by bringing a little bit of a Parks Associates perspective to bear on what's happening in the market right now, as well as some of our consumer survey work. We'll also hear a visionary insight talk from David Barton with Taito Care, as well as Dr. Taldone with the University of Miami Health System about their system's televigilance program. Then Elizabeth Parks will come back to have an executive Q&A chat with Mark Francis, who's the Chief Digital Health Integration Officer with Electronic Caregiver. And in the back half of the session, we'll have a full hour interactive panel with some of the leading experts in the industry, really focused on connected health devices and apps and data, and that how they play and the different use cases that they're focused on in this space. So we'll have speakers from OBrien, from Atrium Health, from Vital Circle, Cloud DX, MMHG, as well as Silicon Labs. Following our session today, after we end at 2:30, we break out into a networking discussion. So we can't flow out into the hallway with you to continue the discussion in person, but we have a Zoom room set up. And so if you'd like to continue the discussion and chat with the analysts, and if any of our speakers can make it as well, we'd welcome you to join us in that networking session. In your platform, as you're viewing this event, there are a couple tabs to pay attention to. So there is a general chat tab that you can put any thoughts or to the team or anything that you want to send our way or to your other audience members. There's also a specific questions tab where you can submit questions to the speakers, and we'll certainly be saving time to pull those questions to our speakers if they're able to answer those. And then finally, a polling tab. And so I believe we have at least one polling question in there today that we'd like to get your insight on some of the topics that we'll be covering. So let's go ahead and set the context for today. I'd like to lay the foundation of our session by focusing on some of the big picture shifts that have happened this year in connected health. You know, going into 2020, connected health solutions were making progress. Much of the technology foundation had been laid to close the gap between facility and the home and to empower consumers with the apps and the insights and the devices they could use to manage their health and wellness. So we had seen a lot of innovation from vendors, a lot of healthcare providers and health systems trialing approaches to make connected care, remote care work in their models, and a start on consumer education about the value of connected health products. Yet connected health to the home or in the home was certainly still at the periphery of what we consider to be healthcare. The concept of patient-centric care still operationally meant facility-centric care. Most virtual care use cases are for, you know, ad hoc, urgent care type needs, or perhaps ongoing treatment after a diagnosis when a care plan is put in place, and for a pretty relatively small targeted part of the population. But proactive care, ongoing wellness, remote diagnosis, virtual monitoring of acute illness at home has really not been at the forefront of connected and virtual care models. But COVID-19, of course, is a sea change, no matter where you sit in the ecosystem, provider, payer, vendor, consumer. We're seeing a new mindset starting to take hold where the home is a viable and valid location for health management, healthcare delivery, and the use cases for connected health at home really are broadening. And of course, if you think about it, you know, the reality is the home is the place where most of healthcare considered broadly actually takes place when you consider what we eat, whether we exercise, whether we're taking our prescriptions as prescribed, or how we interpret those discharge instructions that we received. So home can now be the first place acute care can be received virtually, and chronic care management can happen in an ongoing way. It's also the place many of us continue to work long term. So when we think about health broadly and include fitness, diet, acute and ongoing care, caring for our mental health and the mental health for our children, caring for our elderly loved ones and helping them to live independently, you see the value in a new mindset about what virtual and home-centric care and consumer-centric care can mean. Now, we certainly have seen dramatic increases in telehealth usage this year. About midway through the year in 2020, we had 41% of US broadband households telling us that they had used a telehealth service in the prior 12 months, compared to just 15% in 2019. Now, that does include all modalities, so not just video visits, and includes one of the primary ways that telehealth occurs still today, which is simply using the telephone. Some of the leading reasons consumers do not use telehealth, beyond simply, you know, the number one here is just lack of need. They haven't been ill or had a reason to see a doctor virtually. There continues to be a pretty strong bias towards the quality of in-person care over a virtual care type visit. And the idea that I couldn't possibly receive the same care, being diagnosed with the same accuracy without physically seeing a doctor, or an assumption that I'd have to go into a facility anyway, so why use telehealth first? But of course, it is true that the instruments and data that providers are privy to in a facility setting simply don't exist in most virtual consultations today. So for many conditions or injuries or illnesses, that consumers are correct, they really can't be diagnosed or treated in the same way at home right now without provider and even patient access to the right equipment and the necessary data. Consumers do see the value of incorporating health data or sensor data into a virtual care scenario. So 52% of consumers in US broadband households find a telehealth service that allows them to share data from medical devices in their home during that telehealth visit to be appealing, and that's up from 46% last year. And this rises even further, of course, among those who do already own connected health devices. And adoption of connected health devices, defined pretty broadly, is growing year over year. So 42% of US broadband households report owning at least one in a list of connected health devices as of Q2 2020, up from 24% when we started surveying on this back in 2013. They also own more connected health devices on average than ever before. So 16% of US broadband households own 3 or more connected health devices in 2020, up from just 7% the year prior. So a potential indication of acceleration here. Now, the vast majority of this market today remains direct-to-consumer type devices, so fitness and wellness devices, most notably wearables, smartwatches, fitness trackers. Also, connected weight scales, connected fitness equipment are relatively more commonly adopted. In the connected medical devices category, which includes smart thermometers, wireless CPAP machines, connected glucometers, pulse oximeters, a combined 15% of US broadband households own at least one of these device types. Thinking about all of these device types and the variety of data they collect, a number of new possibilities for connected health use cases emerge, from the more established use case of remote patient monitoring for chronic condition management or monitoring after discharge from the hospital, to diagnostic support for telehealth consultations. Sensors and devices in the home that can proactively monitor and support older loved ones as they age safely and well in their own homes. And this new use case really directly brought on by COVID-19 of proactively monitoring one's health and one's family member's health for signs of illness in order to engage in public life, from travel to education, getting to school, being able to be admitted to school or to the university campus, to just working on site with colleagues and with clients, depending on your employer's policies. I'd like to go deeper here in just 2 areas where we have some consumer point of view, though our speakers today will certainly expand upon a variety of others. First is the use of technology for contact tracing. In the United States, the decision to use smartphones and other technologies to support manual contact tracing occurs primarily at the state level, but we found that the majority of consumers are open to it. More than 50% say right off the bat that they would be willing to share their smartphone data for contact tracing to help curtail the spread of COVID-19. And another 20% said they would be willing to share their data if certain privacy protections are put in place. And of course, that those privacy protections are, made known to them and are transparent to them to increase that confidence. We've also tested the appeal of various approaches to using smart products to help seniors in particular live well and independently, from a traditional PERS style device, PERS being personal emergency response service, right, a panic button with fall detection capability, to a smart watch that detects falls and has a panic button and also detects location and some vital signs. A home sensor-based system with passive monitoring, no devices that really need to be worn, but that can passively detect activities of daily living and detect falls, and a smart speaker or display system. And all of these approaches tested relatively well, with about half of caregivers finding each solution appealing for their loved one. And of the solutions tested, a panic button came out on top. It's also a known solution to a clear problem, but the fact is that even these providers are really not staying in this bucket. They're expanding beyond the basic PERS offering into the smartwatch category, counting steps for a more positive focus on proactive wellness, incorporating passive sensors for activity monitoring and fall detection, and adding voice control as another way to call for help. And smartwatch manufacturers, we've seen in the past year or so, have been adding cardiac monitoring, fall detection, blood oxygen readings, and even blood pressure detection. There's simply so much innovation in this area and in others, pushing healthcare closer to consumers and beyond the facility. So with that, let's turn to our industry experts and hear what they're doing in the connected health market today. And so to start, we're going to hear from David Barton at Taito Care, as well as Dr. Taldone, and give us just a minute for us to bring them into the conversation.
Parks Associates Consumer Analytics Program feeds standalone studies and several ongoing tracker products each year on smart home, security, entertainment, energy, health, and communications products and services. We also survey channel players like home builders, property managers, residential security dealers, and custom high-end installers to get a well-rounded view of consumer technology markets.
Hello, this is Yilan Jiang, Director of the Consumer Analytics team at Parks Associates. Parks Associates surveys 10,000 broadband households every quarter and conducts a variety of surveys throughout the year. These research data are used for syndicated studies and custom studies for our clients. This information provides insights for our clients to understand consumer preference, consumer usage, and their future demand. Turning data into a business strategic action is a never-ending excitement for me. Next, I would like you to meet my team that make this happen. Thank you.
Hi, I'm Keshav Jaiswal, and I focus on solving complex research problems by asking right questions to the right audiences and finding interesting ways to visualize that data.
Hi, I'm Sharon Jiang. I love finding interesting nuggets of insights in the data.
Hi, I'm Shelfan from CA team, and I love survey design, making sure our survey looks clean, thought out, and logical.
The Consumer Analytics team is the backbone of our research team and core to Parks Associates' 35-year history of providing in-depth and high-quality research that inform the strategic decision-making of the top companies in consumer technology markets. We appreciate all that they do.
Great, and we're back. I'm so pleased to welcome David and Dr. Taldone to the conversation today. How are you both? Awesome.
Doing well. Thank you, Jennifer.
Okay. We appreciate you joining us today, and we're very excited to hear about this telavigilance program that you've been working on together, both from the provider view as well as the device view from Taito Care's perspective. So please go ahead and take it over, and I'll be back with Q&A at the end of the session.
Sure, absolutely. So thank you, Jennifer, and extremely exciting insights to share. Just prior to this, right, I think it's certainly a growing trend to continue to see more and more connected devices really exist in the household. And it really wasn't even originating out of necessarily healthcare. We've got a lot of these companies like Amazon, Google, and others who are building these type of connected devices for the home and really paving our pathway forward, making it easier for us to really live in that household and be appropriated to care. My name is David Barton. I lead the Enterprise Solutions team here at Taito Care. I've been with the company now for about 4 years in commercializing our product here at Taito in the US. I'm joined by Dr. Taldone today. She is a tremendous leader at the UHealth, University of Miami. She's their medical director who's been leading a lot of the efforts around telavigilance, and she'll really talk about their entirety of their telavigilance program, which, Taito happens to be a piece of it. But there's a lot of really exciting mechanics onto what they do and how they do it. So she's the real star of today. I'm just going to really brief you guys on a little bit about Taito and what we do. So with that, I'm going to go ahead and dive into the content. So just a little bit about Taito and how long we've been at it. It's always interesting to see kind of on the connected device space, how long this has been ongoing for. And so we've been actually at it for about 4 years in commercializing our product in the US. We were actually founded back in 2012, but it really wasn't until 2016, end of 2016, that we actually attained our FDA clearance and approval in the US. And we began commercializing our product thereafter. And the real goal was really in that first year was to gain market acceptance, to gain market validation that this is a product that can really be accepted by the medical community, that products, like this can basically produce the same type of result as you would in the in-office exam room. So that was a heavy feat to basically go down the path of, and we certainly had a lot of academic institutions, innovation departments across a multitude of health systems and other healthcare ecosystem players that were basically helping us kind of basically propel this technology into the household and into professional environments. Over the course of the last few years, we've really seen a big boom in the connected device space, most specifically over the past 12 months, allowing us to grow a number of partnerships across both the US, but also globally. We now are in over 20 countries, I think 26 or 27 to be exact, and service most of North America, South America, basically almost the whole globe. And so we've really had a lot of traction across the world. We're going to focus most particularly today in the US, most specifically with our partnership here with UHealth and the University of Miami. So to give you a flavor of what it is that we do, this is actually Taito on the most left-hand side here in the image. It's a base device, basically very similar to kind of that cell phone experience. Forward-facing side is an LCD touchscreen, which is really your window into the examination data. And on the back end of the device, that's really where we can transform that base unit into a very high-end digital stethoscope, for example, for heart, lung, gastrointestinal sounds. We have the otoscope attachment that allows you to look inside of the ears. It actually has the industry's first flexible tip, so it's really easy to navigate into your ear or your child's ear. We have the tongue depressor, which basically gets you a really good-looking throat exam, depresses that tongue. And the exam camera is actually built in there in the back. It's a high-definition exam camera with 2 LED lights on both the left and the right-hand side. That's really the secret sauce to a good image. It's that lighting. And then we have an IR thermometer down below for temperature. So very relevant, for the past 12 months, to what we're experiencing with COVID. We certainly saw a major uptick, even with consumers who are actually looking forward to having more of these type of devices in their household. We're not going to stop here. Our clinical capabilities will continue to expand, as you can imagine, with the artificial intelligence, with machine learning capabilities. This is the first of its kind type of data that we're able to capture and record. And certainly there's a lot of things that we can do to provide clinical decision support to enhance the system. We just announced the release of our own pulse oximeter that plugs into the device directly. And we're always looking to continue to innovate in this space. With this whole device and kit, it does pair with an app that runs on a smartphone or tablet, so it's really easy to access and use, just like any of the other apps you may be accustomed to using in your household. Now, a lot of people look at our company and they think that we're a hardware company, we just build devices, and really our bread and butter is actually in the software, because if you really boil it down, we're taking something pretty complex, something that normally would exist in the in-office exam room, and we're bringing that into the comfort of a consumer's home. So it's not enough to just take an otoscope and expect something so clinical to be used by someone who's not very clinically trained. So for that matter, we've invested heavily into that software piece. We certainly have a virtual academy that allows people to watch a series of tutorial videos, learn how to use the product, but most importantly, actually, then thereafter be guided through the different examinations that they can do. So you can do a synchronous exam with a doctor, see them live, be examined in real time, but you can also capture the data asynchronously, and this is a lot of the power that Dr. Taldone would speak to in terms of how their monitoring program came about and how they were basically having students send across data. So we have an asynchronous solution and platform, ultimately filtering and sending across that data to the provider for later review and escalate accordingly to triage as needed. We have a built-in symptom checker based on Smith-Thompson protocols. And to give you guys a little bit of a glimpse into kind of some of that guidance, that navigation, that software piece that really differentiates us, this is an example of a heart exam. And if you think about a heart exam, most patients don't really know where to place the stethoscope on their body. I'd be surprised if they do. And so we actually assist them and guide them through that process. We have algorithms, navigation, and guidance running in that background. So you can see here there's a silhouette. that allows it to be pinch and zoomed into the frame of that patient, allowing them to thereafter place the stethoscope into the relevant points and record as needed. If the, for example, recording is erroneous, we'll actually prompt that patient to recapture that and even give them real-time feedback. So if they're pushing too hard, we'll ask them to reduce pressure. If the room they're in is too loud, we'll ask them to move to one that's quieter. So a lot of that capability is built into the solution to help make sure that we're capturing top-notch data similar to what you would do in an in-office exam room. This is another example here of the throat exam. I would have shown you the ear, but it does get a little, it does get a little too inside there, so I didn't want to make anyone queasy. So this is the throat exam, if you don't mind. It's going to guide you to do the throat exam here, and sure enough, the patient will see that. Go about doing that exam, and they'll receive a green circle and check mark just in the back of that mouth. And you can see the lighting is automatically adjusted, so we're not, expecting people to really finagle with that. It's ultimately built in. This is our synchronous exam. I'm just going to show you a glimpse of it. I think it's important to kind of see the flavor of what this can look like. Those were the asynchronous exams previously. This is if you're actually seeing the provider real time and live. You can see this patient. Here's the provider in that little box, and they have a cockpit of all the different types of exams that they can complete here. They're going to start with a heart exam. They'll finagle and move from point 1 to point 2. They can amplify the sounds if they choose to do so. They can even manipulate the filter. So if you're familiar with the standard stethoscope, there's 2 ends to it. So you can move from the bell to the diaphragm filter seamlessly through that experience and through that process. So a lot of thought, that went into this. It's really built from the clinician mindset for clinicians. And of course, continuing to make that simplicity key on the patient side to basically utilize the product with the guidance, in this case, of the provider. That is the ear exam, so I'll go ahead and skip it, but you can see there can even adjust the lighting there for that exam. These are some of the more popular use cases that Taito has been involved with over the past few years. Certainly the COVID-19 programs that we began to roll out over this past year really took precedence, really pushing this product out into households to do more remote monitoring, freeing up the beds in hospitals to ensure the right patients are in the right place at the right time. But even outside of COVID, there's a lot that you can do with telehealth. There's a lot that you can do with connected devices. We do have a professional grade version of our solution as well, but on the home front in particular, a lot of groups right now are moving into building our solution or other connected devices into, for example, virtual primary care, virtual urgent care, certainly looking at things like pop health. Congress has approved a series of amazing reimbursement programs that the FCC, for example, dispersed in funding last year. They're looking to do another round of that this year, more so targeting those who are in the Medicaid or Medicare bucket. So there's a lot of opportunity. Right now, there's a lot of funding for these type of programs. We even have some programs that are rolling this out as part of a more intensive monitoring experience, going beyond just the standard collection of vitals, but also thinking through how to triage into that next level of, hey, we've got alerts that don't look so good. What do we do at this point? How can we better triage that particular patient? And of course, when you start to think about even the provider to provider use cases, this is actually where telehealth has traditionally been more adopted. Think about places where you're trying to maybe create a specialty triage program, load balancing amongst multiple sites, or extension of care services into non-traditional care settings like school-based sites, employer sites, things of that nature. So with that, I really wanted to keep it brief. I really want to turn it over to Dr. Taldone. She's the star of today. So with that, I'm going to turn it over to Dr. Taldone, and I'm happy to stop sharing, Dr. Taldone, if you prefer.
That sounds like a plan.
Awesome. So I think I can, there we go.
Thank you so much. Hello, everyone. I'm Dr. Sabrina Taldone, and I just wanted to take a brief second to say thank you, David, for that gracious introduction, and also to say thank you to you, as well as the rest of your team, for really being wonderful partners with the University of Miami Health System and helping us really bring our vision for continuing care for our patients in the outpatient setting in a connective way. And we really appreciate everything you've done for us. So thank you. Well, welcome everyone. I'm the medical director for the Televigilance program at the University of Miami. My background is in general internal medicine. I practice medicine in both the inpatient as well as outpatient environments, which really enables me to see where the opportunities lie for connectivity and the future of telemedicine. So I'm happy to share with you today about some of the ways that we've been able to integrate the Taito device with the rest of our corporation. Give me 1 second. All right, so like I said, I'm the medical director. I also have several hats that I wear in teaching and academia, which allows me the opportunity to also share this up and coming technology with learners. I wanted to take a brief moment to start by saying we've done so much in so little time. The coronavirus pandemic has been very tragic for so many, and we were able to work with Taito Care and everyone there to make sure that we could bring better care to our staff, our athletes, our students, as well as our patients. So we're not going to go too detailed into this. I just wanted to show that it all started in the beginning, kind of the middle of June, when we were bringing in some Taito Care devices and starting to adopt it very soon, because in mid-July, end of July was our peak with the coronavirus. We really had to have some creative applications for this device to be able to care for all of our interested populations. And we have continued to be iterative and creative in embracing this new technology to care for our patients. Next, I wanted to talk about the resocialization strategy of the University of Miami. So when the pandemic was at its beginning, we had to cancel all in-person activities and send all of our students home, and also bring back our athletes first in the summertime. So we started doing our, I guess you could say, beta testing in June of 2020 with the return of the student athletes, and then learn from the process of using the Taito Care device with those populations for others in our university. So that would be the trainers, the staff, and then a large principle developed, which was the 4 T's, the tracking, testing, tracing, and telavigilance. So I'm going to go really briefly over these and then kind of talk about the application. So in this example, when we're talking about student athletes, there may be student athletes who returned to campus who were having symptoms of COVID, who needed to be put in isolation in order to make sure that they wouldn't share it with others, or maybe someone was positive or had symptoms that were highly suspicious of having coronavirus infection. So these individuals, whether they were trainers of the athletes or athletes, were given the Taito devices and brought into a comprehensive program that involved multiple agents, being from those in the athletic department to nursing to operations to medical physicians, to make sure that there was a comprehensive process that could integrate the Taito Care device and monitor these patients in an asynchronous manner. We're not going to go into details of this flowchart. It's just to help you gain a perspective that the Taito Care really allows the connectivity, but it's also enabled different parts of our university to connect with one another in order to make sure that it was integrated as a comprehensive aspect of coordinating care for our student athletes. So after that was rolled out, we wanted to bring it to more populations. So we started out with the athletics, including the athletic program members, that being the trainers, coaches, etc. We then had faculty and staff involved, as well as the general student body, and specifically regarding concerns for COVID patients with COVID disease, or concerning that they could have symptoms that may be led later to find out that they have coronavirus. As you may remember, testing was a severe shortage at the beginning of this pandemic. And so this enabled us to even monitor our patients before we knew that they had coronavirus. And then I'm going to spend most of my time talking about how UHealth, so our medical team, has really been looking at more acute cases in the post-admission environment for inpatients, after emergency room discharges, and also ambulatory patients who are part of our population that our providers are normally caring for, coming down with coronavirus or other diseases that needed to be monitored closely. So the University of Miami Hospital, I have a nice picture here, and just to go over that, all of our Miami hospitals were really severely strained, especially in July when we were hitting bed capacities, meaning that patients would come in to the hospital, they'd come into the emergency room being very sick, needing to get admitted to the hospital. But if there aren't enough beds in the hospital, it can be very difficult and dangerous to be caring for these patients, given staffing as well as bed availability. So what we were aiming for was to find a way that we could find the patients who were doing pretty well, either near ending the end of their admission into the hospital, or maybe patients in the emergency room who didn't look quite sick enough to be admitted to the hospital, but would benefit from being monitored in an outpatient setting. So this is the most recent dashboard I have of what we've done here at the University of Miami Hospital. So there were 66 patients who were identified for this remote monitoring program. Again, it's asynchronous. And we were able to ensure that we were following them after they were discharged from the hospital. This was crucial because when patients are admitted with coronavirus, they're, number one, very sick. And when they go home, their first concern is, how am I going to know if I need to go back to the hospital? What about my shortness of breath? Is this a reason for me to go back to the hospital? And so the Taito Care device really allowed us to capture vital signs. So that's your oxygen, your temperature, your blood pressure, and your heart rate, as well as your oxygen saturation, to make sure whether or not we could use this objective data in addition to subjective symptoms to assess whether or not someone should be going back to the hospital, increasing our patient satisfaction, family members' satisfaction. A lot of anxiety was relieved with this. And also to provide doctors as well as our nurses a way to monitor these patients in a collective way within the system. So I'm sure that many of you have lots of questions, but before I go into that, I just wanted to draw attention to the fact that in July, you can see was our greatest peak of when we were having patients that were recommended for these devices. I didn't really go into too much into detail about how we identified the patients who should be sent home with the Taito Care devices. This was done through a collaboration with hospitalists who are doctors that work in inpatient settings to identify patients who are just about ready to go home but could benefit from being monitored closely to help prevent readmissions, which would then occupy another bed, leading to worsened bed capacity. And as you can see in the bottom left-hand corner, the majority of our patients, it looks like we're discharged from the emergency room, but all these other lines are just different parts of the hospital. So the bulk of our patients, which you can see in the right bottom corner about patient class, the majority, around 65% of our patients were discharged with the Taito Care device from an inpatient service, and around 34% were discharged with a device from the emergency room, and really helped provide peace of mind and also connectivity with someone who could help. So I'm looking forward to answering questions from the audience, and I will stop there.
Okay, well, thank you both, Dr. Taldone and David, for that overview. So interesting what you've done. We do have several questions that have come in, not surprisingly at all. I have some of my own questions as well, but let's first turn to the audience questions. So one relates to devices that are already not, this is really for you, I guess, David, part of the Taito Care solution right now. So I think Dr. Taldone already mentioned that in the program that you've been doing, you have been collecting blood pressure, for instance, and that's not necessarily already part of the Taito Care solution. You mentioned you're adding pulse ox. Are you looking to, from a Taito Care's perspective, integrate with companies that are providing, that are third-party device manufacturers, and creating a partner ecosystem, or are you looking to add more peripherals, more devices to the Taito Care package itself?
Yeah, that's a great question, Jennifer, and I think it's a bit of both. I think we certainly are always looking at our product roadmap and working with our partners to determine what are the right types of devices that we should be working towards putting out into the market. We've actually taken a pretty aggressive integration strategy, and I know Andy, I think, is here today. We've worked very closely with OBrien. OBrien actually has one of the best-in-class blood pressures, weight scales in the market. And we worked very closely with their team to actually Bluetooth enable that solution directly into Taito. Quality is absolutely key for us. We are all about quality. We pride ourselves on quality, and so we really look to the best-in-class devices for that. So we're always evaluating our strategy. For things that are well done today, like a blood pressure that OBrien has, we're not really looking to replicate anything like that. We're always looking at the market. We're always looking at the things that more so are more complex, things that haven't really cracked into the consumer's household, and how can we potentially bring more of that into the home. So, looking at all types of, not even just devices, but even thinking about, at-home testing, of various things that we would otherwise do in clinics. I mean, there's a large variety of things that can be cracked, and that's certainly an area that we're looking at. But I know Andy's on, so awesome partnership with Omron. They're a tremendous partner. We have partnerships with Nonin for their pulse ox and others as well.
Okay, great. Thank you. We have another question, which is always the question: who pays? So, Taito Care does have a direct-to-consumer play, but what we've talked about today, right, falls a little bit more traditionally in the remote patient monitoring type play. But also, you talked about the telemedicine program with the athletes. So perhaps there was a university, model there. Can you talk a little bit to the reimbursability of the approaches that you're taking? Who's really paying for these types of programs?
David, you want to go ahead?
Yeah, so it really varies depending on the program that we're launching. I think I had mentioned even in my presentation that there are always opportunities for funding, even from the government. The FCC put out a fairly large fund this past year to help fund or jumpstart a lot of these types of programs. So I know a lot of groups use that type of funding. There's others like the USDA. There's a HRSA grant that actually has some fairly good dollars that's coming out this year as well. For the monitoring type programs, a lot of times these are more value-based contracts, folks that you're at risk for. We have programs where the devices are being rolled out into the health plan. So anything that you can do in those cases to divert visits ultimately lead to cost savings. In the case that Dr. Taldone spoke to, when you have the opportunity to free up beds, that doesn't only mean that you're freeing up the bed for potentially a COVID patient that needs to have that bed, but it's also freeing up beds for the elective surgeries, right? We saw that was a major, an unfortunate situation this past year where health systems had to defer many of those for good reason. And so, the ability to free up the beds allows you to continue to revenue generate. So there's a lot of different ways to look at how to pay for those devices, but it's going to vary upon use case. I know with our relationship with some of the health systems we work with and the retail side of things, it's all about new patient acquisition. How do we continue to grow our patient base and allow them to continue to consume services thereafter? So a lot of different ways to look at it.
Okay, great. We have an interesting question related to capacity issues. So obviously you're using, you have the telemedicine program, you have the partnership with Taito Care in order to address the surge of patients that you had, particularly in that July timeframe you were talking about, and solve some capacity issues for the hospital system. Are you seeing, especially if someone asked, as students return to campus and perhaps waves of how we've seen waves of kind of COVID infections happen, how about the capacity of your staff to manage a remote care program that you're now scaling up and doing more and more of, right? So you've solved perhaps the hospital capacity issue. How about the remote care capacity?
That's an excellent question. And I think it goes into about having these great partnerships with Taito Care and also having, I guess you can say, communication on all levels of the university. So we have scaled up significantly throughout the year, ever since June, regarding the ability to monitor so many patients as your panel audience member pointed out. And so what we've been able to do as an academic center is really hone in on some of that epidemiologic data, not only within our healthcare system, but also our faculty and staff, in order to better predict about what we should be seeing regarding surges and really flux the number of staff that we need to be monitoring this information. Also, we've been able to integrate the Taito Care's vital signs that are coming in directly into our electronic medical record system, which is through Epic. This has allowed us to be able to analyze large amounts of data quickly, which is important when you have personnel doing what can be sometimes manual tasks. So we were able to develop dashboards and collaborate with some of our IT partners in order to try and minimize the amount of actual personnel that would be required. But yes, definitely scaling up and being in constant communication with leadership regarding expectations and trends so that it was a cohesive process from the top down and down up.
That's really great. I mean, the timeline you showed really calls attention to how quickly you've been able to get this program in place, and it's really, really very impressive. We have a ton more questions, but we are out of time. So thank you very much for the interesting insights that you shared. Obviously, it's been highly interesting to the folks who are joining us today because of the number of questions that we've gotten. But we need to move on to our next executive Q&A. So thank you both so much for being here today.
Thank you, Jennifer. Thank you, Dr. Taldone.
Thank you, David.
Well, I'm going to welcome in our president, Elizabeth Parks, who's going to host our executive Q&A with Electronic Caregiver.
Hi, good afternoon, and welcome back to the Connected Health Summit. So thanks for hanging with us while we do a little bit of transitions. I'm very happy to be able to welcome Mark Francis, the Chief Digital Health Integration Officer for Electronic Caregiver, who is going to be joining us today for a short Q&A, talking a little bit about the future of healthcare delivery. So thank you so much, Mark, for joining us. Just a brief background, we know that you have been a leader in healthcare really for years, and prior to working at Electronic Caregiver, have worked as a product innovator for companies like Amazon, Intel, AgeWave, and Health Hero Network. Also a graduate of Harvard and the University of Pittsburgh, as well as being awarded 17 patents. So we very much appreciate your time today and contribution. and want to jump right in and see if you can give us a little bit of an introduction of electronic caregiver.
Sure. Thanks so much. Happy to have this opportunity to do so, and thrilled to be able to join so many distinguished speakers and panelists today. Electronic Caregiver is a digital health technology and service company. We're headquartered in Las Cruces, New Mexico, founded in 2009, so we've been around for a while, really focused on the mission of helping to transform healthcare by providing a platform and services and support to deliver value-based care.
Great. Thanks for that intro. So let's jump right in here and talk about some of the hurdles that you've seen in the past 12 months. So tell me, what would you describe right now as the biggest obstacle in delivering healthcare given the situation we're in with the coronavirus?
Sure. Great question. Yeah. Having had a chance to work in healthcare now for a couple decades, both as a provider and then as a technologist, when I look at our healthcare system in the United States, we've designed a system optimized for providing episodic, procedure-driven, in-person, facility-based care, and we're fantastic at doing that. And we built a payment model around this model of care delivery. COVID-19 exposed the shortcomings of this system. So our immediate need is controlling the spread of COVID and helping people either get healthy or don't get infected. Related to that is we need to provide access to care. That includes both people who are dealing with COVID as well as the millions of people around the country that have other healthcare needs that require treatment and intervention. Lastly, one of the things we don't always talk about is that there's a huge percentage of the population, tens of millions of people, who are chronically underserved and lack access to healthcare. A lot of these folks are from low income and minority communities. Some of the reasons they don't access care is what we're now calling social determinants of healthcare, but that's another set of the population which we really need to help make sure that our solutions help them not just now, but in the future, receive access to care.
Well, that's great. And certainly there are so many factors right now influencing how healthcare is provided to consumers. And really a core focus over the past few years of Parks Associates research has been in that consumer centric perspective, with the idea that healthcare could potentially be delivered directly, in the home with remote patient monitoring. So, of course, as you noted, COVID has been a catalyst for a number of industries in driving things forward, and in healthcare, that's been such a huge industry impacted. So, can you tell a little bit more specifically about the recent grant that you all have gotten from Intel and the COVID to Home program, and looking at healthcare in the home?
Sure, happy to do so. And Elizabeth, you're absolutely right. While we're dealing with this pandemic, one of the things that's fortunate is that over the last few decades, and then accelerated in the last few years, has been a whole bunch of different experiments, waiver program, and other initiatives that started to create the foundation so that we could respond and provide telecare, virtual care, home-based care, and the system has shifted and started to respond to that. Our COVID to Home program, while we developed it locally in New Mexico, is very similar to a program CMS has launched and is now rolling out. That's a hospital acute care at home program. What's happened in New Mexico is back in late October, the public health department, the two hospital systems there looked at a surge of cases of COVID and the pending capacity constraints that were going to hit the system. In 3 weeks, a coalition of stakeholders got together, including us, to develop a program which is called COVID to Home. The goals of the program was to say, we want to make sure we can provide care to anyone needing care, regardless of cost, regardless of language, and regardless of insurance status. Second, we wanted to prevent the unintended community spread of COVID and really try to lock that down. And then third, we wanted to make sure we could optimize resources for the healthcare system. That includes beds, staffing, and funding. So again, in 3 weeks, we went from first conversations, designing a program, creating care protocols, and then having first patient enrolled. What we did is we developed a program that's a 30-day program through which people, if they come into the hospital and they're either tested positive for COVID or at high risk of having COVID, they are enrolled in the program. The program includes the use of the ECG ProHealth Smart Health Hub for remote patient monitoring. The folks use a pulse oximeter, a blood pressure cuff, and a digital thermometer so we can capture those vital signs. On the back end, there are clinical professionals who multiple times per day are looking at the data that's being received. We also push out to individuals the CDC COVID risk assessment survey to again see what might be happening either from a survey response or symptomatics in terms of something happening. We've added to the system a PERS, personal emergency response. We also added a 24/7 access to a teledoc type service that we call Pocket MD. And we make sure that on a daily basis, there is a conversation engagement between a patient and a care professional to help them manage their health status. If something is trending positive or negative, we will throttle up or back the level of engagement that we have, everything from a care coach to a nurse practitioner to a physician as needed. And if things exasperate, we will immediately be able to get somebody in a televisit and then bring them into the hospital if need as well.
Well, I mean, it's truly amazing the speed of which you all were able to roll out a program like that with really such complexity and with such a new condition to deal with. So what would you say might have been some of your biggest challenge beyond just the speed of which you all were executing? And then what have you all been doing along the way with tweaking things since that launch?
Sure. What we did is when we started the program, telehealth, again, was new for a lot of our provider partners beyond virtual visits. So what we wanted to say, a big thing we probably overinvested up front, which I think was really smart in terms of really getting clear in terms of what the protocol would be. So we based it upon a protocol out of Vanderbilt University. We identified and risk stratified 3 different patient populations depending on their symptoms and any other pre-existing conditions, as well as some of the social determinants. Where does the person live? Do they have a care support network? Can we support them? So we laid that all out to be able to implement it. We then started again within 3 weeks, so the week before Thanksgiving, to enroll folks. And over the subsequent 9 weeks, we've been able to optimize the delivery of the program and the results we're seeing from the program. Part of the learning we had was really being able to be smart up front in terms of triage of who the individual is and whether or not we should have them go back to their home to be a part of the program, or we have a local hotel that's partnered with us as well, and they have reserved a wing that's available so that folks can receive treatment in the hotel. So one was just triage and assigning where the patient should go. And then second was the logistics of this. Again, in 9 weeks, we have over 200 folks that are receiving care through this program. By comparison, that represents 60% of the hospital bed capacity in Las Cruces, New Mexico, where this is based at. So by de facto, we've increased the bed capacity by that much. We're doing it at no cost to the individuals. The health affairs shows that a 10-day inpatient COVID cost is just over $14,000. This program for 30 days is costing $300. So we're able to deliver at 1/50th of the cost an opportunity to treat people for a 30-day basis in terms of help them recover from COVID, get back on their feet, get back to work, get back to school, and stop the community spread. So the coalition of stakeholders coming together, kind of putting down, setting aside where they're coming from, and saying, we're going to focus on addressing the needs of this patient population and addressing the community need of delivering this program fast, was really a breakthrough of everybody being willing to focus on the problem and designing the solution, and not kind of where they sat on their organizational hierarchy, because we had an emergency that we needed to deal with.
Yeah, that's awesome to hear companies being able to work together so quickly and maybe put aside some of the things they might have been previously concerned about in implementing something like this. I know for me personally, I check the city of Dallas. The mayor puts out a tweet every day on hospital bed capacity, ventilators in use, and what's available. And I know that metric is of critical importance for understanding, what the overload could be on the healthcare system, and certainly in smaller communities, a program like this having just an amazing impact in being able to free up beds, whether it be for somebody with the virus or for some other health reason that they need to be in the hospital. So thanks for sharing all that. Let's look forward a little bit. We are going to just take a few more minutes to get your perspective on a couple things. So if I were to ask you how you would characterize healthcare now in the present moment compared to 3 to 5 years ago, could you share that with us?
Sure. As I mentioned at the front, I think we have designed a system that was really optimized for the country that we used to be. And I think that if I would look back 3 or 5 years ago, I'd say we were in denial, that there were alarm bells ringing, that things were changing at a significant level, and we needed to reform our system, whether that was the cresting of the age wave, whether it's caregiver shortage, whether it has to do with the shift of an older population dealing with chronic health conditions, medication management conditions, and didn't necessarily need inpatient procedures. We knew all this was happening, but we really didn't take it seriously. We kind of ignored the warning signs. We did tweak things a little bit on the edges, but we really didn't embrace things. To me, COVID was like a kick in the face for everybody, and it's almost as though we're all now in rehab. We have pivoted, we've adopted telehealth, we've adopted virtual care. It took us a pandemic to do so, but I'm glad we have, and we're seeing that it works. Now the real question is, what happens when we leave rehab, when the intervention's over and we go back? I hope and I believe the most effective system, if I look into the future, will be a hybrid model of care that has virtual care, in-person care, at parity, coupled together to serve what the patient needs. And that care can be delivered at home, in the community, or in a hospital setting. The key to make that happen is some of the changes that happen now in terms of workflows, the ways providers provide care, funding, policy, and reimbursement. We need to keep those in place to drive this type of sustainable adoption. I think we've seen that the companies have solutions that work, but now it's a matter of what path forward do we want to choose. Do we want to go back to what our prior path was, knowing that there's issues with it, or are we going to use this as a real inflection point to adopt a more of a hybrid model and really take that new path forward?
Well, that's great. And certainly, technology plays a critical role in the success of everything that we're doing in healthcare as we move forward in the coming years. So I want to thank you very much, Mark, for your time today. Very valuable insights. And so we appreciate you joining us. And coming up next, we have a panel, Connected Health Devices, Telehealth's Missing Piece. So if you give us just a minute, we will bring you back here with our panelists. Thank you so much for joining us.
Okay, welcome back, and let's continue on with our panel discussion. I'm so pleased to welcome really leading industry speakers from a variety of different viewpoints across the ecosystem here. What I'm going to ask is that each of our speakers introduce themselves and introduce their companies, and then we'll dive right into our conversation. So first, we're going to start with Andy Atwell, who's Executive Director of New Business Development for Global Innovation Incubation Team at OBrien Healthcare. Hi, Andy.
Hi, good afternoon. Jennifer, thank you and Parks Associates for including us in today's discussion. I'm the Executive Director of New Business Development at OBrien Healthcare. We are the #1 doctor and pharmacist recommended device for blood pressure measurement. And we have most recently entered the service world by bringing our Vital Sight program, which is a hypertension management platform, to the market.
Wonderful. Thank you so much for being here. We're very familiar with OBrien and very happy for you to be joining our panel today. Next, we have Becky Fox. Becky is the Chief Nursing Informatics Officer with Atrium Health, as well as the founder and Chief Strategy Officer for Vital Circle. Hi, Becky. Can you tell us a little bit about Atrium and about Vital Circle?
Sure. So one of my roles is as the Chief Nursing Informatics Officer for Atrium Health, which is a large integrated delivery network health system located in North Carolina, South Carolina, and Georgia. And then I'm sure, like many of you, when the pandemic began, there was many of us focusing on how we can make a difference. And so that created the foundation of Vital Circle. And it's a company that really tries to focus on prevention, privacy, and peace of mind by bringing data to folks and understanding how they can help prevent COVID-19.
Wonderful. Thank you. Can you tell us a little bit about the Vital Circle application, here we go, on the slide here, and how it might be used?
Yeah, so Vital Circle is unique in that we bridge two different things. So first of all, we have a symptom tracking so that on a daily perspective, you can capture information of your exposures, any symptoms that you might be having. And then we couple that with technology in a wearable contact tracing device. So when you're wearing your contact tracing device, if you come within 6 feet of anyone else, it detects that connection and that contact, and then now you're armed with a lot of information. So what happens is businesses, schools, civic groups have used our technology to really make an impact. When they bring groups of people together, everyone does the daily symptom tracking and then also wears their contact tracing device. And that if anyone comes down with symptoms or if anyone has an exposure, you instantly have data and you can see where your risks are and can really focus and mitigate those in a lightning speed.
Yeah, that's interesting. We've heard about the use of apps, for contact tracing and smartphone. And then it sounds like you're also incorporating a wearable piece. Can you tell us a little bit about how that's worn?
Well, one of the things that we learned in talking with, many people around the United States and beyond is that there's a lot of skepticism of having somebody go into your personal device and using Bluetooth technology. And so what we found is, employers, schools, civics groups really need to protect entities and protect their employees, their participants, but we also understand we need to respect and protect their privacy. So again, back to that situation where employers come to work and they put on their contact tracing device, wear that while they're at work, but then when they leave, their privacy is protected. And then that way, you know exactly what's going on when they're together or in a work environment. And again, at the moment that you know that you have a risk, you can instantly focus your team. So you might want to think of it like with different businesses, distribution centers, for example, or one great example where historically, if anyone comes down with symptoms of COVID, you might have to shut down an entire line. Now, when you have this contact tracing information, the moment that 1 or 2 employees come down with symptoms of COVID or have an exposure, you instantly can see all their points of connection and don't have to shut down your business, don't have to shut down your school, don't have to cancel your event. And our technology has been really successful in this. One of our first clients was the Republican National Convention, where we were able to help keep both the citizens that were participating in the convention, but also the citizens and community of Charlotte really safe, because you had all that instant data. So the moment they had any type of risk, they were able to intervene within minutes, and most importantly, continue on with their important work of having the convention.
Okay, thank you. I know I made you do a longer introduction, but I wanted to make sure we understood exactly what, that vital care solution, or vital circle solution is. So thank you so much for
Appreciate that. Thank you.
Yeah. Next we have Anthony Call, who's the co-founder and COO of CloudDX. Anthony, welcome.
Thanks very much. Great to be here, and thanks to the Park Associates team and Jennifer putting this on. This is terrific. CloudDX is a virtual health platform, and we do full suite of RPM products and software. We're a device manufacturer as well as software platform, so we make or curate the devices that go into our platform. Quality of data is very, very important to make diagnostic decisions against, so we can talk for hours about that. Our current use cases out there in the world, both in the United States, across the US, and in Canada, are COVID virtual outpatient programs. This concept of being able to free up space and decant COVID patients who are symptomatic and positive but stable into the back at home, and monitor those patients and look for exacerbations, bring them back into the care continuum if needed, but really reduce the burden on the system and improve their outcomes. We do a lot of post-surgical remote patient monitoring to reduce hospital readmission programs. Hopefully to be published in the next month or so is a 900 patient trial we just completed for post-surgical that has amazing results. And we also do traditional chronic disease RPM, so monitoring our most expensive rind of patients, CHF and COPD and that kind of stuff.
Wonderful. Well, thank you so much for being here as well. And next we have Dr. Raj Padwal, who's the CEO of MMHG.
Great. Thank you very much. It's a pleasure to be here. So I'm a professor of medicine at the University of Alberta in Edmonton, Canada, and also CEO of Millimeters Mercury. We're focused on creating simple but elegant cloud-based software solutions for chronic disease management. A particular focus is high blood pressure. We also really focus on evidence-based practice because of our clinical and academic backgrounds. So creating efficient products that allow practitioners to really in a seamless and default way practice in an evidence-based manner. A major partner is A&D Medical, so creating software solutions that pair with their excellent connected devices.
Wonderful. Thank you so much for being here as well. And finally, we have Emmanuel Sambui, who's the Senior Director for Consumer and Healthcare at Silicon Labs. Emmanuel, how are you?
I'm very well, thank you. How are you doing, Elizabeth?
Great, thanks. Tell us a little bit about Silicon Labs.
Exactly. Thank you for having me. So as you said, I am the marketing director with Silicon Labs with a specific focus on consumer and healthcare. Prior to this, I've been working in semiconductor for over 20 years with in a number of places. But with Silicon Labs, what we have is a specific focus on the IoT market. We actually generate hundreds of millions of dollars in this specific business. And what we have for time is specific competence around wireless connectivity products. Of course, as a semiconductor company, we are, I guess, one of the foundation blocks of all the other people here in the panel. We build the little things that people do not want to hear about, but that gives you the ability to build great products for our customers and the end users. We're, of course, a hardware company. As you know, semiconductor is basically a market of scale. So we ship hundreds of millions of products, and IC, hardware ICs. But one of the specific things as well about Silicon Labs is we have invested many of our resources and our OpEx into software. And when we talk about connectivity, and later we will be talking about security, that's one of the things that we're pushing, and that very much right now, and that is a differentiated factor for us, specifically in digital health.
Well, yeah, it's interesting to have tracked the IoT space for a long time, which we do at Parks, beyond the healthcare ecosystem, and to see the applications of IoT now in health and from the home out to the facility, as we see a lot of the remote patient monitoring programs coming in from the facility into home. So interesting to have your perspective as well. Thanks for being here. Well, so I'd like to start off in going back to something I was talking about when I set up this session generally, which is really the role of devices in the virtual care connected health ecosystem generally. I think that the services, have come a long way this year. We saw a dramatic uptake of telehealth consultations, but the devices and the data that's being captured aren't necessarily always there. So I'd love to just get your perspective on the role of devices in the connected health ecosystem today and the extent to which they're being used. And perhaps we can start off with Anthony here.
Yeah, so I think that you've hit the nail on the head. The role of the device is really the role of the data that you're trying to capture. If we sort of break it down into two value propositions for a clinician when it comes to a virtual visit and managing a patient virtually with data or without, it enriches a virtual visit. So if you're in a virtual visit with a patient, the importance of the data that you're driving from the SpO2 or the temperature or blood pressure or visual means of being able to look at wound care and things like that, it's just as important as it would be if you were in an in-person visit. So in that acute environment, it's very, very important and can add a lot of richness to the virtual visit. It can also stop you from having to bring that patient in and escalating that virtual visit to an in-person visit. And then on the chronic side, it really does establish a baseline and allows you to do trend analysis against vital sign metrics with devices in the home that you would not normally need to do. In fact, all of us, I think, who make these types of devices would agree that blood pressure specifically, to make diagnostic decisions against blood pressure is actually better to have a nice long tail of at-home quality blood pressure metrics as opposed to white coat syndrome induced in-clinic metrics. So the role of these devices is to provide outstanding, linear, trendable patient data to make diagnostic decisions on.
Yeah, absolutely. And same question to you, Andy. What are your thoughts about the ways in which devices are really being incorporated in connected healthcare today?
Sure, thank you. And Anthony couldn't have set it up better for me. As the manufacturer of a blood pressure monitor, that's what we are really focused on, is building a history of accurate data that's available to the clinician as well as the patient, so that they have something to talk about, they have a history to look at, have an understanding about their chronic disease. So at OBrien, we particularly focus on hypertension, which is one of these diseases when not under management requires continual by the physician. And in the time of COVID, where they are discouraging individuals coming into the clinic for fear of exposure, but that doesn't, preclude the fact that these people still need regular care and monitoring for their hypertension. So using platforms to gather that information, the home really becomes an extension of the clinic. And having devices with clinical accuracy at home and being able to transport that data securely is very much a real possibility. And it's represented here by OBrien and my other colleagues that are joining us today.
Yeah, absolutely. Beyond the remote patient monitoring use case, so one thing I think, Anthony, actually you just mentioned was the idea that even from the diagnostic perspective, right, if you're calling into a telehealth service, right, being able to see data coming out of devices is pretty compelling. That also presumes that the devices are already in the home as opposed to having been provisioned to the home. What's your perspective on how or if there's an opportunity to have more devices that are really penetrating into consumers' homes?
Well, for us, I think that we'll get to the point where your home will have a medical kiosk in it at some point in the future. That concept of the Star Trek tricorder vision, where if your daughter is complaining of an ear infection before school, you go to the tricorder and enact an immediate virtual visit. You've got, a Taito Care otoscope, you have temperature, you have You have diagnostic testing for saliva and all the rest. I mean, that will be the vision. I think that that's ultimately the place that we'll go to completely democratize medicine that way. I think that there's a role to play to B2C consumer devices now, and certainly in where we're seeing penetration in the market for companies like ours is in really expensive patients or chronic disease managed patients, where giving them a kit of gear makes a lot of economic sense, and that's the thin edge of this wedge that will move forward into a much more sort of consumer experience.
Yeah, I think that makes perfect sense. So let's talk a little bit about how the connected devices and sensors you both mentioned, dramatically increase the depth or quality, perhaps, of the of the visit, and the physicians in particular ability to see what's going on. Also expands what you can use telehealth for, right? Or that expands what we can think of our use cases for connected health. Let's talk about a little bit more about the new use cases your organizations are serving, and where you see the most potential growth. So we go back to Becky here. The way that you're using technology for contact tracing is obviously comes directly out of the pandemic, and is something that really wasn't on anybody's radar a year ago. Yet here you are. So tell us a little bit more about how your technology is being used, and maybe are there other adjacencies? Are there ways in which you expect this kind of technology to expand from where you're at now?
Yeah, I think Anthony and Andy really helped frame that there is a shift, but the pandemic has changed many things, and it has also changed our perspectives of where health needs to occur. So we all know that many wanted us to get to a place where virtual care was just the norm. And I would say, if we went back in time 5 years ago, people would say it's going to take us a long time to get there. And now, of course, the mindset is, well, why haven't we been there already? So this whole concept of having technology on you or a part of your work or part of your experiences is going to continue to evolve. And so, what we're hearing and what we're seeing is people want to leverage technology so that you can empower folks to make decisions. So when you have a workforce that you need to keep safe, that you need to help, that impacts your business and your ability to serve your customers or consumers, then you have to use data whatever way you can, and yet at the same time still respect those privacies, still understand how you can ensure safety of everyone, and keep your businesses and keep your consumers moving in the right direction. And so I think the expectation and the culture of the world is going to expect these types of things to keep us safe. So when I go to an event, for example, if I'm going to go to a conference that now has 10,000 people, the reality is not everyone's going to have the vaccine. Not everyone's going to have herd immunity, but yet we still have to have our economies open. We still have to get together at conferences and large mass groups of people. So how do we do that in a safe way? And that is by bringing technology, combining sources of data, and then leveraging that to make a difference to everyone that's participating. So whether you're using technology in your home, whether you're using it in your business, your school, or your any activity that you're going to be doing, I think there's a huge shift in the culture that people are going to expect that you do that. They expect for you to keep them safe as a participant, and that's going to be the new norm going forward.
Yeah, I was gonna actually, and you touched on it just at the end of your comments there, but ask, once there is a post-COVID, if that even exists, there is some talk, of course, that the virus itself will be around with us for a long time. Do you expect that it will essentially be an expectation, even after the direct immediacy of COVID-19 is gone, that my health as an employee or an attendee or a student or a staff member is still going to be this, this expectation that others are looking out for my health when I'm at their facility?
I do think that that's going to be the expectation, that we know that we don't think that this will be the last pandemic, that there's going to be several iterations. And so it's going to take us quite a number of years to really wrap our arms around this and make sure that as a society, whether it's in just the United States or beyond, are really safe. And the way to do that is by leveraging technology and putting it in the arms and of those that are keeping your businesses, your schools, and your entities open. So we've got to get there in protecting folks. And the way to do that is with contact tracing, capturing symptom information, and then, of course, course, leveraging other services that the panel is talking about, virtual care, et cetera, and really using our technology so that we can keep our economies open.
Can you tell us a little bit about, is there certain sectors that you're seeing the most demand in right now? So is it mostly events-based, or employers or universities, right? Is there a certain sector that's most demanding these types of solutions?
Yeah, we're really seeing it across all industries. So event space is probably the best one, that because people want to get together for a 3 or 4 day event. And so that makes the most sense, that you bring all these people together, you contact trace them so you know all of the interactions that occur. And then, of course, you can continue to monitor them even after the event to make sure no one develops symptoms in those 10 to 14 days after the event. And then, of course, communicate with everyone to make sure everyone knows if they've been exposed or had any risk. But we're also seeing a big uptick in schools, and because these are just natural places that people come together. And what I like to remind people of, I'm of a few decades old, and for these several decades I've been on the earth, it's those are my habits to get within 6 feet. So even though we can put up signs to remind people to wash your hands and be protective, the reality is that's not our nature, and that's not what we've been doing for our entire lives. And so there's just a reality that schools are going to still continue to struggle with exposures. And if you have exposures at schools, they take it home. We're still going to have exposures in businesses that will have to shut down, or we even see it in the healthcare sector in particular. And we know we have to have our healthcare folks available to take care of patients. So, when we talk to healthcare organizations, that's their big struggle. They could have a 36-bed unit and they have 50 or 75 different staff members, and or 1 or 2 of them come down with symptoms, they have to test the entire unit. And so it just makes a manpower, a financial challenge to do that, as opposed to having a dashboard that I can quickly look at. And at 6 o'clock in the morning before a shift starts, I instantly know where my risk is. I can isolate the people that I need to, and I can keep the unit functioning and lower my costs while at the same time mitigating those risks. And then what we're also hearing, whether it's in schools, healthcare, industry, what we're hearing is that both the employees then feel safer, because I know you're monitoring me only when I'm at work, but now I know that you're keeping me safe. You know what's going on with all of us and how we're interacting. And so the instant that you have information, we're able to really jump on that and make a difference. And so what we're hearing is that the teammates actually value that. And then, of course, what it allows you to do is communicate to the world that these are the efforts that you're doing. So from a business's market perspective, that helps them with ensuring to the public that they're providing and really taking all steps that they can to make sure that everyone's safe.
Yeah, really interesting. Next question, Raj, can you talk to any new use cases that you're seeing for your technology and your solutions kind of rising out of this past year and kind of going forward, where the opportunity is in the connected health space?
Yeah, thanks. I think when you take a step back and look at care provision in the clinic, it's a paradigm that's quite well worked out. So you can basically plug and play what you want to do in a clinic environment, because that's something that's been around for decades. I think that a lot of practitioners like myself were blindsided kind of with what happened with COVID, and I agree with my panelists. It's a great development that virtual care has been accelerated, but the virtual care visits are a little bit rudimentary in the sense that, you have a video or a phone linkage, but you don't really often get all the data, and it's very patient dependent in terms of how the quality of the data that you're getting. So we're really focused on best clinical practice, and what we try to do is enable providers to measure and monitor the chronic diseases in an efficient way, but also something that is underpinned by the decades of research that have occurred in the past. And if we take hypertension as an example, I totally agree with Andy. It's one of the most important conditions out there. 100 million Americans are affected by it. I would push back a little bit on what Anthony said, in the sense that I don't think you want to trend it daily and look at it every day, because that's not really where the clinical evidence sits for hypertension. It's really getting a core set of values to estimate that person's actual blood pressure. And that's usually across clinical guidelines in the world between 3 and 7 days. And then you make a diagnosis, and then you want to titrate therapy. But you don't really have to monitor in between that. You can do it a month or a month and a half later. And so these are things that providers are not really well focused on in the virtual care environment. They're very used to it in the clinic environment. And that's one of the things that we bring to the table, is to try to help providers align their virtual care in the best manner possible.
Yeah, thank you. I think we need a little audio feedback there. There we go. Yeah, Raj, that's really interesting, because what you're also speaking to there, a lot of times we talk about in connected health, whether or not you need a device to be, a one-time use, an acute diagnostic type role versus an ongoing, all the time monitoring or daily monitoring. Well, there's some conditions and some use cases where it's a week or it's these specific days, and it really complicates the matter, because you have so many different conditions, so many different device types, so many different vital signs that are going to be unique to that care condition, and really speaks to why everyone really is looking to the B2B side and provisioning and coming through care providers versus the direct-to-consumer play. I mean, there are certainly strengths and weaknesses to both, but I think what you're talking about really speaks to the need for providers and provider systems to be able to have a strong role in shaping the solution that's most appropriate.
Yeah, and I'll just quickly add, when you look between hypertension and, say, post-acute care, the post-acute care environment is where you have the daily readings, whereas the hypertension environment is where you want to do it in a different way. And so these paradigms, these flow charts of how to care for each condition, they're in their infancy. People aren't used to doing it virtually, and that's what we need to develop.
Interesting. Well, let me turn to Emmanuel. So very interesting, again, perspective coming from the silicon side, coming from the IoT side, thinking about wireless infrastructure, which I know that you do, wireless standards. Can you talk about use cases from your perspective, maybe starting from the consumer side or starting in the home, and what you see as new, potential possibilities there?
Yes, absolutely. I can make a parallel with the home. Actually, I don't know how many products you have at home that are wireless connected, but you probably have more than what you think. Let me just give you some examples. You might have a voice assistant, that is Wi-Fi enabled. Your water and gas meters are very likely monitored continuously by the utility company delivering to you, and that's why you can connect to their website and see how good you are with your own consumption. Your garage door opener, probably another wireless system. Your thermostat might be now Wi-Fi enabled as well, so that you can actually change your thermostat while you're remote. Maybe you're on vacation and you want to come back and you want to put the heat up. So the reality is, inside of our home, it's actually pretty easy to find like half a dozen or even a dozen products that are already today wireless connected. There is one element of complexity in the home, is the variety of all these technologies that have basically to work together and coexist in the home environment. On the healthcare side, there is a clear winner. So that's the beauty of this and I think it was Becky who said it before, it's Bluetooth. Bluetooth has been selected as kind of the best way to connect portable medical products for patient monitoring. There are multiple advantages to Bluetooth. First, it's ubiquity. It's been deployed into hundreds of millions of smartphones, heavily used on a daily basis, so it's a very robust technology. Second thing, it's low power. One of the things we haven't told yet is the majority of remote monitoring products are actually battery powered. And they might have different lifetimes, but it's very important to understand that as soon as you deal with the battery, you need to keep the power down. And the last piece is the security aspect and the privacy of the data. And of course, in healthcare, that's a very big thing. Well, Bluetooth initially was not designed to handle data privately, because if you remember the origin of Bluetooth, it was actually designed for earbuds and Bluetooth audio solutions. So data privacy was an afterthought, but it quickly came into Bluetooth. And since the Bluetooth version 4.2, which was deployed a few years ago, there is now a privacy feature deployed in Bluetooth. So if you want to make the parallel with the home, I would say I completely agree with the panel. We're going to see more and more digital connected products on the healthcare side, the same way we are seeing it on the home side, with the difference that the technology of use is very low. I'm not saying we won't find other corner cases, but for the majority of specifically patient monitoring in products, Bluetooth is going to be the clear winner. The big advantage of Bluetooth is it connects to your phone, and which you can use as a gateway to basically transmit the data to a remote location. So if you want to connect to your doctor or your hospital, the Bluetooth can give you the in-home connectivity solution, and then the phone is going to give you the mean or the media to basically convey this information to your doctor, who could be sitting miles away. And that's the beauty of Bluetooth. So I think if you in terms of use cases, one big thing that is common, that is a very strong care about in medical and healthcare is the data privacy and the security of the data communication.
Yeah, absolutely. I have a follow-up question for you, but first I want to bring our audience's attention to the polling tab. So we do have a poll question in here. If you haven't had a chance to visit that yet, I'm just going to give you a minute to get your answers. And we have a question to the audience, which is which connected health use cases will see the greatest growth in 2021? The options being disease or illness monitoring for travel, employment, and schooling. Telehealth diagnostic support, whether that be acute or urgent care type needs, ongoing chronic care management, post-discharge monitoring, independent living or aging in place applications, as well as fitness and wellness. But let me come back to you, Emmanuel, while people are getting their responses in here. So one thing that folks who may not be in the tech side very much, but maybe are on the healthcare side, hear probably a lot about 5G and advances in cellular technologies. And one of the application areas on the health side that people are talking about on the cellular side is that there's an advantage of, for folks who don't have a smartphone, let's say, or might have trouble with pairing. If you have a cellular-based health device, it's essentially plug and play. It has its own connectivity, right? It could be provisioned from a provider, or through a management provider of some sort, and then it kind of just works. But there are obvious, probably cost advantages to Bluetooth. So can you talk a little bit about, for folks who maybe don't live and breathe the technology side of this, what they might be hearing about 5G and versus the types of approaches that you're taking from the Silicon Lab side?
So absolutely. So you made a very good comparison between 5G or cellular, and Bluetooth. And basically what we tend to say is Bluetooth is a short range type of communication and cellular is a long range type of communication. And both can actually coexist, and they do coexist in your phone. So your phone has got both on board and they work very nicely together and you can use both. I don't want to go too deep into the details, but there are obvious pros and cons for either solutions. You mentioned the one for cellular where you basically avoid the need for having a gateway product in the middle. So you don't need to communicate to your phone and relay this information to something, at a distance. The one technical penalty that you're going to have with cellular is the power consumption. Mm-hmm. It might be a concern or it might not be a concern. Let me just take two examples. If you're using a pulse oximeter, for instance, and you are able to change the battery on your own, great. You might accept to basically change the battery more frequently than you would do it with the Bluetooth solution. Now, some other products, and here specifically about chronic disease, one of the big transitions that has happened in the past year, and is still happening as we speak, is in the diabetes side with the move from blood glucose monitoring to continuous glucose monitoring. Because one of the big benefits of remote patient monitoring is the ability to continuously monitor the data. There is a big shift happening right now in diabetes where people are adopting more and more continuous glucose monitoring. And these are basically a form factor. These products, you can't change the battery in those products. So depending on the product you use, you will actually see pros and cons for either technologies. We fundamentally that depending on the use case, people are going to adopt one or the other. If you want to track people, individuals, Bluetooth would be great. If you want to track your pet, I would recommend to use cellular, because I cannot guarantee that your pet is going to stay within the distance of the home where you can actually get Bluetooth to work. So depending on the use case, both things are going to coexist and work together. But the thing is, what I want to bring as a message is these technologies exist, are well proven, and can be used, in a large number of end products from a medical perspective and or other applications. So they're absolutely us to use them.
Interesting. So the results of our poll, there are 3 kind of lead use cases that folks have settled on. 26% said telehealth, we'll only let them choose one. So 26% said telehealth diagnostic support. Also 26% said ongoing chronic care management. 22% said disease and illness monitoring for travel, for school, for employers. Only 11% said independent living, aging in place, which is really interesting. There's been a lot of attention from our perspective at Parks on the senior community this year. They're particularly, of course, at risk for poor outcomes from COVID-19, and that social distancing has really exacerbated some of the social isolation that population's already kind of privy to, and put a particularly new burden on caregivers to care virtually, right, for an aging family member. So we've heard a lot of talk about aging in place and independent living this year, but most focus on telehealth diagnostic support, chronic care management, remote patient monitoring type use cases. So let's turn now to business models. So the technology for virtual care and connected health products, the technology layer has really been available, right, to use for a while, and its sustainable business models have proven a little bit more difficult. Given the shifts in some of the regulatory and reimbursement landscape, that we've seen this year, what does that mean for the business cases for connected health solutions? And perhaps we can go back to Raj here.
There's a couple comments I have to make there. The first would be, as a Canadian looking at the American system, so take this with that in mind. It does seem that the business case kind of revolves sometimes around generating the revenues rather than the clinical care component of it. And so I really do believe, sitting in Canada with more of a socialized system, there needs to be better focus on the patient and on enabling the care providers to do the best job that they can. I think that the costing structure for some of these codes is a little bit focused more on process and rather than care provision. And so that probably should change. And I think then the business models would make more sense. So for example, for us, we're mostly focused on right-siding that costing structure. And we look at and talk to a fair number of providers that tell us, the revenues don't flow down through them. And that seems a bit bizarre to us sitting here in Canada, because the frontline workers are the ones doing the work. And so, if the revenues aren't flowing down through to them, they're not really incented from a financial viewpoint. So I think that that's a big issue. And regulatory wise, I will throw in one other thing. In the blood pressure space, there are a lot of devices out there, regulatory wise, that are not actually accurate or have not been tested for accuracy. And so this is a big and underappreciated issue. And if we look, so it probably encompasses all the different devices used in connected health, but if we look at the blood pressure use case, for example, when you say FDA cleared, that just means you're on the market. It doesn't actually mean that you actually look to see if that device works in the intended population. And there's a big global push on this by a variety of academic institutions and partners. And it's really our hope that awareness is raised so that when you're procuring a device for your solution, for your clinic or your hospital, you really look at, okay, is this accurate? And there are registries that list accurate devices. Like, for example, in the US, the American Medical Association has done a lot of work on this, and it's called validatedbp.com. It doesn't list all the good devices, but it's a start. Otherwise, I would say you should always be going with upper arm devices for hypertension care, because that's what a century of research has focused on, and validated devices. And, when you look at reputable manufacturers like the Omrons and the A&Ds and the Welch Allens, those are the companies that spend a lot of time on accuracy. So this is a big regulatory issue that I don't think is widely appreciated.
Well, thanks for bringing that up. To be highlighted here today. When you're talking about two provider systems or folks who might be looking to add, right, a solution or add a blood pressure cuff, to their portfolio, do you find that they are starting to ask for that, to look beyond just basic FDA approval, to a higher standard of certification or efficacy?
Yeah, I think awareness is at ground level on this issue, and that's why I wanted to raise it. So I just don't think a lot of people know about it. They assume that FDA clearance means accurate, and it doesn't. And so, I think we got a lot of work to do on this end.
Okay. Well, Anthony, let me come back to you on the reimbursement and regulatory side. Do you see how things have shifted this year? What new possibilities are out there? And actually, we do have a similar question from the audience asking for the panelists' confidence that we can get reimbursements for telehealth and remote monitoring to not conflict with delivery networks' financial model. So, can you talk a little bit about the reimbursement state today and how you see that?
Cloud DX operates in both Canada and the US, and in our US deployments, it started not just because of COVID. We've really seen both the managed care side and the CMS and private insurance side really invest in a code architecture and in a reimbursement architecture that's recognizing the value of remote patient care and the value of patient-generated data using devices in that stream. So we've seen that building over the last few years, and it really kind of was really sort of brought forward during COVID when a bunch of emergency codes were given out and parity was given out. And I think we're going to see some of those that are being effective. They're going to continue on into 2021 and beyond. I think that to some of what Roger was saying about the Canadian side, because we've got all sorts of business there as well. In Canada, when a province decides and elects that it's going to do this, they tend to do it on a larger scale, but they don't necessarily wrap primary care into it as well as they could. And there is a gap there in reimbursing doctors to coordinate that type of virtual care. That's improving, and we hope to see that continue to improve. But I mean, I think it's here to stay. I think the genie is out of the bottle. I think that the payers, whether those payers are private or public, are recognizing the value in remote care and virtual care and devices in the home and quality devices in the home. So I see that as being valuable. On the regulatory side, I mean, absolutely, accuracy is precision. We talk about, the table stakes of FDA and Health Canada clearance are just that. They're table stakes to get into the game, and then it becomes a real question about precision and accuracy. And so studies and clinical trials, I would disagree on the whole. It has to be brachial. I'm a big fan of the Series 8 wrist cuff that Omron has. I think it's a gold level in Canada and is on the validated BP cuff stuff. So I'll give a shout out to one of my friends there. I think that might be outdated. There's movement artifact you've got to take into effect, and we make a wristbound cuff and spend millions and millions of dollars doing so. But I think that regulatory environment, in every RFP we answer, that always comes up. Not just, of course, you've got to have an FDA cleared device, but what are the follow-on studies? What are the correlation studies have you done? What populations does it serve? And show us the efficacy of that product. So I think that that's going to continue. I think we're fortunate living in North America that you know, it's rare that we get products that are completely out of whack. We're generally lucky to have decent products in our clinics and our care facilities. So that part is good. But I'm optimistic that 2021 and beyond is going to be good on the reimbursement side and on the financial vehicle side that's driving this. Because at the end of the day, you've got to follow the money to a certain extent.
Right. Well, and I'd love to bring the same question to Andy and also give you a chance to talk about, you know, accuracy and precision of measuring through your devices. But also on this reimbursement side, so we have seen some acceleration. If you think about the business models from a larger perspective, not only being B2B and reimbursable, but also the direct-to-consumer market, which of course OBrien has some business there as well. Do you think that the acceleration on the medical side and the payers means that most of the attention and development will be going there? Is the direct-to-consumer play still attractive?
Great question. And OBrien has been active in both the B2C and the B2B businesses for quite some time. I think they serve a number of different purposes. I think the B2C is very good in preventative care, so aware of what your numbers are. You know, for a long time. Blood pressure, of course, is very important. But now that we are faced with challenges in hypertension, with over 117 million people in the United States with hypertension, and over 37 million that have uncontrolled hypertension, moving to a B2B model where it's sort of enterprise-grade management and direction for the patient is becoming increasingly more important. And as mentioned earlier, this has been compounded as well by COVID, sort of the new constraints we have for healthcare now. I'll want to reflect a little bit too about the shift in payment, which is interesting. I mean, there's a lot of great veterans on this call today, including Mark Francis, and you know, Health Hero Networks is one of the very earliest intellectual property around remote patient monitoring. We got patents on using telephone lines to transfer information, and I would say the technology hasn't, unfortunately, been what's been holding it up. Health Alliance in 2006 when they were setting up Bluetooth, as Emmanuel stated, as the standard for connectivity for health data and how to move health data safely. A lot of these solutions have been available, but it took something like the pandemic to really drive the adoption of these and to change the workflow of the clinician. And so I think that's been critical. One thing to note, you know, there's definitely a benefit having reimbursement, but right now the codes are specific to people under Medicare and Medicaid coverage, and not necessarily offered or covered by private insurance or other insurance to all subscribers. So there's a lot of benefit that can still be brought in. Where in the past, as the solution provider, you had to prove the ROI, why someone would want to bring it in and pay for it, that you just place that amount of costs and other expenses in the care of that patient. When you get to the point where the federal government is willing to pay for it, I'm pretty sure it's bringing a benefit, because these guys are not too, you know, loose with the coverage that they'll provide unless they see that there's an actual impact in outcomes and a reduction of costs. So I think we'll continue to see certainly greater awareness and upticks in the business that we have in selling our blood pressure monitors through retail pharmacy, because of the component of cardiovascular with COVID. People are going to want to be more aware of how their heart is doing, what their blood pressures look like. But certainly, additionally, in managing these chronic conditions outside of the clinic and keeping better tabs on it at home, but having that data shared with clinicians, the B2B side of the business is going to be increasingly important.
So thank you, Andy. Now we had a little bit of trouble with your audio. I could hear you though, so I'm going to kind of restate a little bit of some of the points that you were making, just to make sure that we're bringing those great insights forward, and hopefully I'm capturing them well. So you were mentioning that there was a lot of that really the technology has been in place. You talked about Mark Francis, you know, and Bluetooth, and you know, things are kind of settled on the technology side, ready to go, and it's the business model that has been holding things back. And now when you see government payers getting into the market and actually saying this is worthy of doing, that's a really clear signal that there's value here, because they're not, spending their money on anything. And then finally, just the fact that there has been raised consumer awareness, right? Consumers are more aware coming through this year of what's possible with virtual care. And that really has been, and we've seen this in our data too. I mean, it's just this level of consumer education that didn't exist before, that's kind of been forced on everybody. And I'll also mention provider education, that providers have been forced into virtual care that may have been resisting it in the past. So hopefully I kind of brought forward some of the insights that you shared, but we were just, having a little trouble with your audio there. Okay, well, so let me turn to one other question, and then we have a couple other questions from the audience that I want to bring in as well. Actually, let me jump to one that I know we had a question on earlier. I'm not sure if I'm seeing in this panel earlier, but across the board, there's this question of after COVID, right? What sustained demand do we see for these? We have to assume that the use of virtual care telehealth maybe won't be the same as what we saw at peak levels when people could not access care anyway. They could not see their doctor any other way. If you wanted to see your doctor, it had to be virtual. However, what's going to stick? What level of usage do we see? Where is demand going to be? And so maybe we can go back to Anthony on that question.
Yeah, I mean, I'm biasly optimistic in this front because it's important to us, but I certainly think that as I mentioned, I think the genie's out of the bottle. I certainly don't want to go back to a world where virtual care isn't available when I go to visit my doctor. I had a medical consult last week with my doctor. I was able to show my vital sign metrics because, of course, I have some gear in the house, potentially a few pieces, and it was just such a better interaction. I showed up at the right time. They showed up at the right time. It was over in 11 minutes. There was no parking. There was no driving. I could get on with my day. So I think that that's there. I think that what else has been opened is we talk about it internally. We say, come for the COVID, stay for the RPM. It really has opened clinicians. It's changed the mindset of the value of virtual care as a tool in the toolbox for clinicians. And I think if we see adoption beyond 2021 and sustained adoption, it's really because that mindset was resistant to change before, because change in medicine is hard. And now that they've seen that change and clinicians have interacted with virtual care and they've taken care of, potentially they've deployed virtual care where maybe they wouldn't, to take care of patients that were high risk they didn't want to bring into clinic, and now they're realizing this is a really efficient way to manage my hypertensives or my COPD patients or my CHF patients. This is efficient. They're getting better care. My satisfaction scores are higher. And these guys were right. This is a better way to care for patients. And we see that in our deployments. We see, 4 years ago, we see pilot deployments for 200 patients in a COPD clinic that were only supposed to be pilots, where at the end they said, this is, our ethics officers having problems with going back to the original standard of care. We're going to just continue to maintain this rollout. And we're seeing that in almost every, certainly COVID decanting or virtual outpatient program we're doing. That device kits and that connectivity is all going to be re-rolled into a chronic disease at the end of this program. I think we're on our way. I think that we really are going to see a sustained benefit from this reawakening or awakening of virtual care.
Well, we see that in our data as well. You mentioned about satisfaction rates, and most of the telehealth users overwhelmingly tell us that they had a positive experience. And surprisingly, older consumers are even more satisfied, I think, because their expectations were so low coming in, because they were the most resistant to it before this year. So people are having some pretty good experiences with it.
It's complete common misconception that old people don't like technology. They love technology. They just have no patience when it doesn't work. So as long as it works and as long as it's providing benefit, they love it. You need to, usually, if somebody has this wonderful world of virtualized care in their home, you have to use a crowbar to get it out of there. They love it. They think it's great. They have access to their data. They feel empowered. They know what to do when they have an exacerbation. They're ahead of their nurse when their nurse calls. It's just a better way to provide care.
Yeah, not to mention, we talked about social determinants of health, things like transportation and elderly, patients being able to get to the facility. There's a lot of things that we're not even thinking about that might be value adds. We unfortunately are at time though. So I want to thank the panelists so much for all of your insights and for joining me today. Up next, as I mentioned, we do have networking discussion breakout. Our team will be putting in the chat tab of your viewing platform the link to the Zoom breakout discussion if you'd like to join us there. And then also I'd love to draw your attention to our next event, which is April 14th, where we'll actually have two-hour sessions just like today. One focusing on leveraging the smart home for a healthy home. We've seen a really interesting some really interesting data and conversations that have been happening about air quality in the home, about passive monitoring for seniors and other folks in the home. So I think that'll be interesting, as well as seniors and caretakers serving a massive population at home. Again, just a reminder that we do have these sessions all year, and we do have our call for papers open. So if you're interested in participating as a speaker or sponsor events, you can visit our website to submit to speak. And with that, again, thank you all so much. Thank you for attending and for the wonderful questions that came in. And thank you to our speakers for joining us today.